Thanks everybody for coming, and I just wanted to want to say thanks to Mark and for putting this on, and thanks everybody for joining. It's a pleasure to work with Bioness. As you know, I've been a practicing clinician for about 30 years and specialized in neurostimulation and neuromodulation in general. And I've taken a position as Chief Medical Officer for Bioness, and really excited about this technology. So today we have a couple of guys joining us who are really the leaders in implantation of these devices. First is Einar Ottestad, and Dr. Ottestad is clinical associate professor at Stanford in anesthesiology, peri-op, and pain medicine. And he is one of the world's experts really in ultrasound and musculoskeletal ultrasound, and particularly with its use in neurostimulation. He's going to be president of the World Academy of Pain Medicine Ultrasonography in 2017. And I also want to welcome David Spinner. Dr. Spinner is an assistant professor in rehab medicine at Mount Sinai in New York, and he's originally from New York, went to Emory. He is an all-around great guy, and has a good chunk of the world's experience in peripheral nerve stimulation, particularly with the Bioness device. And so I want to introduce Dr. Spinner, I believe, who's going to go first. Is that correct, Mark?
Dr. Ottestad is going to go first.
Okay, got you. So Einar, I want to turn it over to you, and we look forward to your presentation. And just for the attendees, if you guys could all use your chat function and send me a couple of questions, and I'll make sure they get asked, or I can give you a little answer during the course of the webinar by way of the chat back and forth. Okay, so all right, so take it away, guys. Thank you very much for coming, everyone.
All right, thank you, Eric, for that introduction. So yeah, I essentially started using StimRouter about a year and a half ago, and it took about 6 months before I realized how much it's really changed my chronic pain practice. So as you can see here, just for the folks who haven't actually seen the device, is on the screen on the left side, we see the actual implant. So the U-shaped lead on the right side, you can see a couple of soft plastic / rubber tines that actually allow the leads to anchor in pretty much any soft tissue. And we see 3 tiny electrodes on that tip. And then on the left side of the U, we actually have the radio frequency antenna that transmits to the external pulse generator we see in the picture on the right. So in essence, the thought is to take that electrode part of the lead, put it as close to your target peripheral nerve as possible, then simply tunnel the antenna under the skin in a location that can fit the battery patch. And in general, I think of this as trying to create a sort of a triangle with the battery patch being the third side and the lead being the other 2 sides. And in some ways, it makes sense just to think about it that way, because what you're really trying to do is complete the electrical circuit. Other configurations will actually also work. It just may not be quite as efficient in terms of the power that's required. In the middle, you see the patient controller, which really just has 3 main buttons, on, off, and more power and less power. The buttons on the side will actually help you change programs, but I would say most of my patients, they need a bit of programming in the beginning as the nerve kind of fibroses in, and then they tend to be pretty good with it. Next slide, please. One more. In terms of the disclosures, mainly Bioness and some other companies that aren't really related to this at all. Next slide. So this is probably the most important slide that I want to talk about. So if I look back 5 years, 6 years, really I was starting to get pretty good with ultrasound, and I could find a lot of these tiny various peripheral nerves, do very discrete exams, look for abnormalities, but also do very discrete nerve blocks. So a lot of pain that used to be called CRPS of the leg now became a tibial neuropathy or a superficial peroneal neuropathy or a sural neuropathy, for example. So I was able to diagnose this with a couple of milliliters of local anesthetic, but I never really had a good option. So sure, steroids, maybe 5–10% of my folks would have some sort of prolonged relief, but the vast majority, they would just have relief when they were numb. The next step was always pulse radio frequency, and I recall probably having 20 or 30 various pulse radio frequency procedures over the course of a week or two. really any peripheral nerve all over the body, the pulse radio frequency actually works pretty well in the right patient. I would typically tell folks that 50% of people get 50% better. People with more kind of clean psychosocial profiles tended to do better, but people that came in the complete 10 out of 10 pain category, really pulsing was never quite sufficient for them. The much bigger problem with pulsing, at least in the US, is simply the lack of coverage. That has always been the case, but it distinctly changed about 3-4 years ago. And now I can only pulse maybe one nerve a month with insurance coverage. So this takes me to about 2016 when I started freezing all these peripheral nerves. And I should mention, in terms of thermal ablation, I've tried probably 20, 30 times to kill a discrete peripheral nerve with heat. And pretty much success rate has been 0 to 10%. And in those 10% of folks who came back and said they were better, clinically, they wouldn't have any areas of numbness, any specific discrete neurologic deficit that would confirm that it actually ablated the nerve. Then the next step after that will be seeing the peripheral nerve surgeon. Certain nerves, ulnar, median, even tibial, tarsal tunnel, clearly get better with well-known areas of entrapment. But other nerves, lateral, femoral, saphenous after knee surgery, those more peripheral cutaneous nerves tended not to get better with the surgery. And then we move to what I consider the big guns. That's the interaxial stimulation and the intrathecal pump. Overall, this process took maybe 1 year, maybe 2 years to get from new patient visit to diagnosis to finally having an implantable device that actually helped the patient for more than just a couple of weeks at a time. Then with StimRouter starting a year and a half ago, what I realized is I'm really just wasting a lot of time trying to get insurance approval for pulsing, trying to do cryo. Even when the cryo helps and they don't get neuritis, I have to repeat it in 3 or 4 months. So all those patients I was freezing every 3-4 months, I started moving over to StimRouter. And guess what? They stopped coming back to see me. They didn't need to have another freeze. They were simply better. So I revised my entire algorithm to be more aggressive in the PNS. However, getting close to the spine, I still consider more of the big gun. So at this point, I simply want to do a diagnostic block. And to be clear, not because the diagnostic block will predict that stimulation is going to work. The diagnostic block just tells me I'm stimulating the correct target. So now I go straight from the block. If the block works and the patient has a pretty clean bill of health otherwise, including I still tend to do psychology evaluations about 90% of the time, then I move to the StimRouter. So now it may be 2 months or 3 months before I take that patient to the final procedure that's really going to help them long term. If the PNS works, if the StimRouter works, but it's not sufficient, then what I'm doing these days is going straight to peripheral nerve surgery to release. Actually, I like to combine that with the StimRouter as well. I had a case just last week with someone who was in 10 out of 10 from meralgia paresthetica, not classic meralgia paresthetica. This was someone who had status post a lateral approach to the hip for a replacement. So she had significant neuropathic pain in that distribution, but the source was primarily thought to be post-surgical. So I was able to place the StimRouter about 6 months ago, and it completely took care of all her cutaneous pain, and she was able to wear pants again. But there was a deep component to the pain that never got better. So last week, I essentially went to the OR with my peripheral nerve surgeon, and he used the original StimRouter, the guide, to dissect down to the nerve. And sure enough, the inguinal ligament was extremely tight. So he released it. But we finished off the case by me putting the StimRouter back on that nerve in now the open wound. So over the course of the next few weeks, I'll see how that combined approach is going to work. But essentially, StimRouter is really good for the neuropathic component to the pain. If that's not sufficient, then sometimes a release is needed on top of it, not necessarily in place of it. And then the next step after peripheral stim and peripheral release surgery, that's when I would consider cryo or another attempt at thermal ablation these days before going neuraxial. Next slide, please. So in terms of my approach, I had a tibial StimRouter just about 2 hours ago. Essentially, I talk to the patient in pre-op. I tell them about the procedure, about the fact that I'm going to stimulate the nerve and ask for feedback. And then I tell them I want them back after 5 to 7 days just for a simple wound check, and 10 to 14 days for programming. Now, I should mention the reason for the 14-day programming is historically the fact that this external battery more or less sits over your wound. But there are some minor adjustments that can be made that will actually allow you to place the battery on day 0 and start using it right away. However, essentially today for the tibial nerve, I place the patient prone, and before any sort of prep and drape, I pull out the ultrasound machine, I find the nerve, I trace it up under the soleus, a little bit proximal, and I mark my incision site and mark where the electrode is going to lie approximately on the skin, and then I think about designing that triangle for the exit wound for finalizing the tunnel. And at that point, I turn the leg over to the pre-op folks, the nurses, and they do their prep and drape, and then I do the procedure. One of the reasons for doing this pre-draping planning is I've had a few cases in the beginning where I had an excellent sterile field for my incision and for placing the lead, but I found myself short on tunneling space. So you really want to make sure that enough skin, enough limb, enough trunk is exposed so that you can tunnel a good 7 to 10 centimeters away from where you make your stab incision. I also make a point here over healthy non-allodynic skin. So specifically, I don't really try to target the nerves in the area of allodynia. I'm generally going to want to go proximal to where the nerve is more healthy and the battery won't hurt by simply placing it on the skin. And of course, you want to avoid the joints, especially the hip, for the lateral femoral nerve or the ilioinguinal nerve in terms of planning your tunneling. In terms of imaging, I've done 100% of these with ultrasound, but certainly a paresthesia-based technique is reasonable. You still have to have a pretty advanced understanding of the anatomy if you're poking these instruments around looking for a paresthesia, but certainly many people have done that. For certain nerves, such as suprascapular or axillary, the fluoro approach actually does add a significant amount of information, but for something like a common perineal or tibial in the mid-calf, I think fluoro is less useful to help with that. So with ultrasound, for folks that are a little bit familiar, I mostly use an in-plane approach. So think of it as any sort of regional anesthesia nerve block. The short axis over the nerve, the needle comes in plane from one side or the other, and you stop a little bit short of the nerve and inject. With this, my approach is essentially similar. I generally go in with an 18-gauge introducer needle first, trying to follow tissue planes, not go through as much muscle. And then once I get close to the nerve, I put in the probe and pull the 18-gauge out. The 18-gauge is great because it's blunt, so you can really go in there and try to touch the nerve without causing problems. But it's sometimes hard to get through certain fascia, especially the crural fascia. So with the implant approach, you have kind of the traditional view, short axis over a nerve. So it's the most comfortable way to find nerves, I think. And I think there may be some safety benefits in that you always know where the tip of your sharp instruments are. Now, that stated, Dr. Spinner will talk to you about an Autoplane approach, which is what he's done most of the time. And guess what? It works just as well. So it really is up to you to use the imaging modality of your choice and decide on which approach you're more comfortable with. These days in my practice, I would say I'm still about 80-90% in plane and 10 to 20% out of plane. Next slide, please. So with the one slide back. Yeah, so with the Autoplane approach, you have to think about not being able to see the entire needle. You're really just looking at a short section of it. That's why I write it requires a bit more technical skill, a bit more understanding of how everything works. But with a little bit of practice, that approach is just as easy as in plane. Once we have our kind of location for start, we make that stab incision. I mentioned the 18-gauge spinal needle replaced with the probe. With the probe, I'll now do my first test on the nerve. And really, it's just to confirm that what I found on ultrasound really is the correct nerve. And that's really all I want to use the probe for. At this point, since I'm coming in plane and going across the nerve, I'm going to deliver the probe either above or below the nerve, wherever the fascial plane is, maybe by 1 centimeter. So I want to go past the nerve a little bit. And then the next step, I've already made my stab incision. Now it's the introducer sheath. And this frequently requires a little bit more power. I always warn the patient about this may take a little bit. Give them a little fentanyl. And I drive the sheath in almost to the tip of the probe before I grab my ultrasound probe again. And what I'm trying to do is place the white part of that introducer sheath essentially immediately above or below the nerve. So I'm not, if you imagine the nerve being round in a clock, I'm targeting 12 o'clock or 6 o'clock and going a little bit past that. I'm not targeting 9 o'clock or 3 o'clock, which is directly at the nerve. There may be some safety benefits here in that my sharp edge is always past the nerve, so there may be less chance to damage it. But the most important reason I do that is my next step now is to remove the introducer stylet. I'll check one more time with ultrasound to make sure that that white part of the sheath is still on top of the nerve. It hasn't pulled back. And then I just put the lead inside the sheath and pull the sheath out. I don't actually do stimulation at this step. I found that placing the lead visually with ultrasound when the sheath is in the correct location and simply pulling out the sheath gives me a much higher chance of first pass success when I test on the lead for that first time. And also with a pretty reasonable ultrasound machine, you can actually see where the lead is inside the sheath. It shows up very, very bright and white, so you can place it exactly on top or under the nerve. And then just pull the lead back. That electrode will then deploy. It's lying there immediately on the nerve. And it's perpendicular to the nerve, with my thought being you may actually tickle more of the fascicles that are going up and down by placing the lead in that direction. But functionally, I don't really have any evidence for in-plane or out-of-plane being significantly better. After this step, I simply have to tunnel to that predetermined location. And 99% of the time, I finish at this point with just a little dermabond. Just hold the skin together with forceps. Once in a while, if I have to extend that stab incision, I'll put in one single stitch here. And then I'll put in on a tegaderm, maybe a telfa, and that's it. Next slide, please. In terms of the paresthesia testing, I just described to you how these days I'm relying a lot more on just the image that I can see. And I just test once on the paresthesia probe and once on the lead after I deploy it. However, as I was learning to do the procedure for my first probably 20, 30 cases, I paresthesia tested religiously. What I found is typically on the probe, I always get stim at 1 volt or less. The reason I say 1 volt is because I'm implanting this usually on thick nerves. So sometimes it's hard to get that 0.5 volt that we always shoot for. But I'm pretty happy with 1 volt on the probe. Once I do my dilation, I'll still test on the probe again. Usually it gets a little bit higher because we've moved the tissues around some more. There may be some local edema, extracellular fluid. And then I'll put the lead in the sheath and I'll test on the lead before deployment. And here I'd usually be happy with 2 or 3 volts. So the trend seemed to be that as the procedure went on and on, my stim would be a little bit higher. And at the very, very end, sometimes it would be 3 or 4 volts after deploying the lead, even though the lead looks really good on ultrasound. I'm not really sure why that always happens. My suspicion is just because 20 minutes into poking in one little spot near a nerve, there may be a little bleeding or, as I said, some extracellular fluid floating around. That makes it more difficult to stimulate. But the important point is anytime I've had stim on the lead at 5 volts or less, when that patient came back for programming, so that's about 50 so far, they've always been very, very happy with the result. So I tended to chase the low voltage a lot in the beginning. Now I tend to chase it a lot less. And I think actually my success rate has gone up a bit with that visual confirmation. Next slide, please. In terms of nerves implanted, I'll tell you briefly about my approach and why I did it. So suprascapular, probably 8 or 9. About half of these were patients who've already had 5 shoulder surgeries or even a total shoulder. And I'm really thinking of this as post-surgical neuropathic pain at that point. But interestingly, I've had 3 or 4 patients who were wheelchair bound with MRIs of the rotator cuff that showed it was essentially not repairable. So they really needed surgery, but they didn't want it because that would mean 12 months of basically not being able to wheel themselves around. So I tried 3 or 4 stim routers in that scenario, and every single one actually worked. And in some ways, I would consider this more of an MSK type of pain rather than a post-surgical neuropathic pain. My initial approach was just like a block medial to lateral in the supraspinatus fossa. One trick for doing that is don't do it perfectly in the notch. Go a little bit into the fossa, because that dilation sheath is challenging to get through really tough ligaments, even if you can get your 18-gauge introducer needle in. However, one of my colleagues, Michael Gofeld, as well as David Spinner, introduced me to a spinoglenoid or infraglenoid approach to the suprascapular notch that's Autoplane, and I've actually started doing that with great success now. He'll probably talk to you a little bit about that. Next, superficial radial or ulnar or even median. Even if I do the blocks in the forearm, I've generally done my stimulators in the upper arm. Reason for that has been mostly to have a little bit more meat to work with, but also it hides the scar and hides the battery even under a t-shirt. So even if it's a superficial radial issue, radial tunnel issue, I've typically been targeting the radial nerve above the elbow after it leaves the spiral groove. Ilioinguinal hypogastric. Typically, we do this block medial to lateral at the level of the ACES. That can be a little bit challenging for the placement of the stim router, depending on the size of someone's abdomen. But my approach there is essentially to use that classic location to find the nerve and just trace it up a little bit over the iliac crest. And that gives me a bit more room to maneuver. It also takes me a little bit further away from the pathology, which typically is groin surgery of some sort. Genitofemoral. This is more of an approach where you go over the inguinal ligament, you get a long axis view of the iliac artery turning into the femoral artery, and in men look for spermatic cord, and women round ligament. This tends to be a more technically challenging block, even with ultrasound. So definitely I rely more on the paresthesia testing when I do this. I should mention that another one of my colleagues, Mark Hurdle at Mayo, he told me about his first genitofemoral placement a couple of weeks ago, where he was able to actually place the lead inside the spermatic cord itself with really good success. Lateral femoral cutaneous. This is another really high volume, probably 10 to 15 stim routers. Classic location for me with ultrasound is simply finding the sartorius coming off the ACES and tracing down 1 or 2 centimeters, and you'll see the lateral femoral nerve cross from medial to lateral in that location. My approach generally will be to come in on the lateral side here and tunnel down, and that way I'm able to put all the hardware below the crease of the hip. And I mentioned earlier, this is one place where I've successfully treated kind of a superficial neuropathic pain with the lead, but I did have to follow up with an actual decompression because of a very tight inguinal ligament. Next slide, please. And probably 2 more high volume blocks. One of them is Saphenous. So post-shoulder surgery pain has been a big indication for me. Post-knee surgery pain is probably the biggest. So at least 15 plus post-TKA or post-multiple knee arthroscopies with a infrapatellar branch of saphenous neuropathy. The most important trick here is to try to figure out if it's a saphenous nerve or the infrapatellar branch. Now, why is that? The main reason is the infrapatellar branch comes off kind of variably in the thigh, and if you want to treat the knee pain, you have to stimulate the saphenous nerve above the infrapatellar takeoff. But that inevitably ends up being in the adductor canal right on the femoral artery. So I've tended to avoid placing the lead right on an artery. So typically I'll go a bit more distal to the adductor hiatus and figure out which nerve is the saphenous and which one is the infrapatellar branch. They'll look about the same, very, very superficial in the fascia, and touch them individually with the stim probe and then take the one I need. Infrapatellar for knee, or saphenous if I'm really treating foot pain or ankle pain from ankle surgery. There's been 2 cases where someone had either a previous saphenous transection, in which case I didn't really have a choice at the knee. I had to go in the proximal thigh. And the other one was someone who did have infrapatellar branch neuropathy, but they also had shooting pains down the leg. So it was both saphenous and infrapatellar. So in both of those cases, I did go ahead and place the lead in that adductor canal near the artery. Next, posterior femoral cutaneous, posterior pain, especially when sitting with numbness and paresthesias. Typically, I just find this over the hamstring. And then lateral and medial sural cutaneous, you find these in the upper leg, or sural, common, you'll find down by the Achilles tendon. So it depends on where the pain is. For the sural cutaneous nerves, typically it's pain in the back of the calf from compartment syndrome and the release. And then the sural nerve typically is from ankle surgery, where the pain is just down below. So I've put the StimRouter in on both areas. And then if you want to get complete sciatic nerve blockage, typically I put the lead between the common and the tibial, right at the split in the popliteal fossa. My reasoning there is that way, hopefully more of the electric field will penetrate both branches. Next slide. And then superficial perineal, just in the middle of the calf between lateral and anterior compartments, very, very straightforward. And then my other big volume implant is tibial nerve. So for 10 years, pain on the plantar surface of the foot has always been a bit of a puzzle. It's really hard to capture that with stimulation. But StimRouter's basically been 100% for me for virtually any cause, idiopathic neuropathy, but pain in the bottom of the foot. The one caveat I would say is, in one case, a patient had terrible pain down there, responded to blocks, but during the implant, I could kind of jam at that nerve over and over, and he never really felt a paresthesia. And in his case, the implant actually didn't work. So I think the take home is you need to have enough nerve that's still alive in order for peripheral nerve stim to work, or you simply go more proximal on the same nerve. So if I ran into that situation again, I couldn't elicit a paresthesia on the stimulation probe. I would simply go 15, 30 centimeters more proximal in that limb. And finally, the pudendal nerve. I've done several of these, and this is really the only one where I think migration can be a problem. Of all the other nerves I've mentioned, they really haven't migrated much at all. But both of my pudendal implants migrated, and I think the main reason is really you're sitting on this 30 minutes after surgery. So I've thought about restrictions. For example, I'll probably try to keep people maybe even prone in recovery, and prone for a day or two if they can. Try to avoid sitting on that, sleep on their stomach. And I'm also going to adjust my technique and not target it right at the ischial spine between the sacrotuberous and sacrospinous ligaments, but I'm actually going to go about a centimeter more distal in Alcock's canal. And I think the StimRouter tip will anchor much better there in the obturator internus. And I think that's my last slide.
Great, thanks, Einar. So one of the questions we had earlier, can you hear me?
Yes, we can hear you.
Yeah. So thanks, Mark. So one of the questions we had earlier, Einar, related to the block, or the trial block, or the trial injection or nerve block prior to placement of the StimRouter. Can you spend a couple of seconds on the technical pieces of that, volume, et cetera, and what you're looking for with the temporary nerve block?
Yeah, that's actually a great question, and one of my former fellows texted me about that today. So the overall philosophy with chronic pain is you want highly concentrated local anesthetic, and you want to use as low volume as possible. So just remember that 5 cc's of 1/4% and 2.5 cc's of 0.5% will give you the exact same amount of nerve block, but the higher concentration one is going to be much less likely to go spread off somewhere else. One reason I want to say that specifically is it brings me to my only missed implant. So I had a gentleman with actually kind of a lateral neck pain, maybe under omohyoid, that didn't respond to local injections in the neck. And then one of my colleagues decided to do a brachial plexus block, which did help with this pain, but that diagnostically didn't help me that much. So when I saw him back, I did a suprascapular nerve block with I think 5 cc volume. I guess what? That was the first time his pain went away. So in his case, I actually scheduled a pulse radio frequency, which didn't work, but it did allow me to block that nerve one more time. Once again, with 5 cc's, his pain went away. So I implanted him. A fantastic stimulation to the shoulder at maybe a 0.5 volt. He used it for 2 months, but it never helped his pain. So what I realized with that experience was because I used so much volume in the suprascapular notch, some of that volume actually flowed back under the omohyoid along with the nerve and blocked the brachial plexus, and actually did block whatever is the cause of his pain. But the suprascapular nerve was actually never involved in his pain syndrome, even though he responded twice to quote unquote a suprascapular nerve block. So because of that, I want to use low volume, I want to use high concentration, and I want some clinical evidence of a block, not necessarily just pain relief. So I always ask them if they had an area of numbness and where that was. And ideally, the pain goes down when they're numb and the pain comes back when the numbness wears off. In many ways, like you would use it predictively for a lumbar radio frequency procedure.
Very, very helpful, Einar. Thanks. If you guys, any of the attendees have any further questions for Dr. Ottestad, just shoot them to me on the chat function. And next, in the last 25 minutes or so, I want to introduce Dr. Spinner. David, welcome, and we look forward to your presentation.
Great. Good evening, everybody. My phone connection is good, but my network is not great. So I apologize if I'm off the slides just a little bit. Okay. I want to talk, sort of piggyback a little bit off of what Einar was talking about as far as techniques and my change in practice. But first, let me talk about some of the indications. So I really help with a physiatric physiatry sort of pain practice for Mount Sinai. So we have a unique patient population. So we see a lot of rehab patients, so a lot of post-stroke shoulder pain patients, phantom limb patients, and a couple others. Right. So historically, our treatments for both post-stroke shoulder pain and phantom limb pain were really focused more on physical occupational therapies. Sometimes block or some maybe neurostimulation or some in different types of injections, but it was really very, very limited. And one of the things that we've been able to do now, because a lot, especially in the post-stroke shoulder pain patients, a lot of these patients really have pain because their shoulders are at a mechanical disadvantage. The shoulder is subluxed and literally in an incorrect position. So you can imagine, having one of your joints in a chronically subluxed, almost a partially dislocated state. So that certainly makes it difficult, right? So one of the things that we do now is we're able to stimulate the axillary nerve. You can stimulate your deltoid, which essentially is putting your shoulder back in place. So we've been using the Violet StimRouter for really the majority of our post-stroke shoulder pain patients with great success. Another population is our phantom limb patients. So we've had numerous patients with a combination of either below or above knee amputations that have done well with targeting the sciatic nerve to provide some relief. Now we target the sciatic nerve in a few ways. Sometimes we will split the tibial and perineal distributions, and a number of cases have actually placed, because the sciatic nerve is really two nerves, we sort of think of it as one, but it's really two nerves. I'll often place two leads on either side of the sciatic nerve, one towards the tibial component, one towards the perineal component, because they're big nerves to make sure we obtain nice coverage. So the indications in the rehab world have been a little different. What's been interesting is for a lot of our nociceptive sort of mechanical pain. Right before, it's been a lot of steroids, a lot of injections, to the knees, to the shoulders. A lot of these patients are much older, sort of non-operative. Right. So even though the indications are typically we think of more for neuralgia, I begrudgingly early on with a couple of patients said, let me just try it. Let me see what happens. So I had a number of patients. We did a shoulder or knee, for patients really just non-operative or even on blood thinners. And interestingly, the patients received really great coverage. A little unexpected because it wasn't a true neuropathic etiology, but it tells you a lot about how much I think we don't know is about the nervous system and how it carries and transfers our pain fibers. Well, the other indication that's been a big winner for us that we see a lot of total joint pain, mostly knees and shoulders. Most patients typically do well, even after a tough rehab program. But for the patients that are remaining that still have chronic pain, we've been able to provide nice pain relief with implanting for both the shoulder and the knee. Now, the shoulder is interesting because there's really a dual innervation to the shoulder between the axillary and suprascapular nerve. I know in the pain world, historically, it's been thought of as a suprascapular nerve, and there's no question the suprascapular nerve covers a large part of the shoulder. Eventually, the axillary nerve covers a decent portion as well, both to the teres and the deltoid as a motor component, but as a sensory component as well, and each patient's a little different in their coverage. So I found that doing some diagnostic blocks gives me a little bit of a sense of a degree of pain relief for which nerve for that patient maybe providing the majority of relief, or even then doing dual implants. Okay. Now I'll jump a little bit to my techniques. So I'm an ultrasound person. I have ultrasound, but I also do a lot of fluoroscopy. And what's interesting is actually the dual use of ultrasound and fluoroscopy together for a number of these cases has been very helpful for me. So I'll give you a few examples. So pudendal nerve is a nice target with ultrasound as it sits next to the artery. But if you don't have a great ultrasound machine or a tough body habitus, fluoroscopic guidance is sometimes just easier to go to a certain landmark. So I've done cases with a combined approach with ultrasound and fluoroscopy towards pudendal. Intercostal is also another great one where a combined approach I think is very helpful to ensure the appropriate level as well. Another one that we like to do is suprascapular. You know, ultrasound is my preferred method for it, but it is not inappropriate to use fluoroscopy as well to make sure you visualize the notch well, to make sure the lead is sitting down where you'd like it to be. My approach differs a little bit from Einar as far as in and out of plane. I typically like to use to visualize the nerve out of plane because the nerve itself has a nice little honeycomb appearance, and I think of it as sort of playing darts. It's a little silly, but that nerve is my target, right? And so I find it easy to see the target, you know, in short axis, that axial cut of it, instead of looking long on a nerve. So when I see it that way and then come out of plane, that needle tip or the stimulation probe, that's my dart, right? So obviously we go slow with it. We don't take a sharp needle directly at the nerve, but the stimulation probe is blunt tipped. So once I advance down close to the nerve with our 18 gauge spinal needle, I transfer out and use our stimulation probe to go that last little distance, so I can lay flat on the nerve. So I like to lay long on the nerve. We don't really know if long or short on the nerve is better. So far, the results seem to be about the same. So I think that the jury's still out. But I think if you're on the nerve, we're getting coverage. I think that might be the moral of the story when it's all said and done, as far as the approach. My practice has certainly changed. You know, I used to do a whole lot more cryoablations and RF. You know, my algorithms friendly has changed. You know, I don't know about everyone else out there. I got a little, along with the patients, a little needle fatigue with the same patient coming in over and over and over again for an injection. You know, you really want the patient to do better and not have to, you know, just go through so many interventions over and over again. So this has been a nice approach to sort of come in much earlier in that process. So I do like to do a diagnostic block, one, just to see if the nerve, if we get some coverage in that area. But the other thing the diagnostic block does for me, it allows me to visualize that nerve before I get to, you know, a surgery center or an operating room to actually do an implant. So it gives me sort of a practice run at that nerve to make sure that I see it well. I think of a nice safe approach to the procedure itself. What's been great about this device as well is that because it's really designed and really built for the periphery and non-spinal, I have not had to hold anticoagulation for my patients. So in the rehab world with a lot of these stroke patients, you know, a lot of the older population as well, it's been very interesting to be able to do, you know, shoulder, knees, a lot of these implants for patients on anticoagulation. My procedure itself, you know, my first, you know, handful of cases, you know, I would take my time. I scheduled them a little longer. Now they're going a little faster. And I've learned a little bit along the way when doing it. I switch from a 15 to an 11 blade. I make a nice stab incision. The two main reasons really for doing it, the dilator sheath has to get through the fascia when you're ready to insert that. So I get that sort of step done to make sure that the fascia is opened up a little bit early on. The other reason is that the skin seems to approximate well with little derma bond at the end of the case. So in the first few cases, I was suturing. In the last 35, 40 cases, I haven't used any sutures at all. I just closed a little derma bond in either steri or tegaderm or some gauze after that. So it's been a lot easier. One of the things I like to do is actually make a loop without making a pocket. So it's an interesting approach. Based on the lead length you have left, it changes. It gives you a sense of where you're going to place your receiver and where that location is. Now, the lead is fixed at 15 centimeters, so you may need all of it to place the receiver right where you want it, and that's it. Right? But often for a superficial nerve, I assisted on an ulnar nerve just earlier in the week, and it was very superficial, right? And so we wanted to take out some lead length. So we were able to purposely tunnel the wrong way with the receiver, and then back to the direction we want to go, to essentially make a loop, make a pocket for the lead without actually having to open up and do a cut down and open up and make a pocket. So it's been a nice way of doing it. I get asked a lot about my outcomes for these patients, especially compared to the original study. And it's interesting. We'll do a formal comparison soon. But I think my outcomes have really been excellent. I've been very pleased. And in the original study, a number of the physicians were not necessarily using ultrasound; they used a nerve finder, and they got very good results with that. And with our ultrasound capabilities, we could literally see the electrode sitting on the nerve, which I think gives us a marked advantage over the original study. So I'm really excited to see what our results are when we pool everything, because this will be one of the few cases where the actual clinical outcomes, I think, when a device comes to market, will be better than the original study. So I'm really very excited about that. Okay. So I talked quickly. I apologize for that I'm having a network issue. I don't have all the slides in front of me. I think I touched on the majority of items that we had planned for this evening. So I'm going to kick it back over to Dr. Grigsby.
Great, thanks, David, and thanks everybody for listening. David, one of the questions, I think one of the most exciting applications of this is the tibial nerve stimulation, because that plantar surface neuropathic pain has been impossible for us forever. So the question is, for those of us that don't have gifted ultrasound skills like Einar and David, is there a different approach to the tibial nerve that we can be successful without great ultrasound skills?
I think you can be. One of the things actually that's interesting, where Einar and I differ a little bit, is he mentioned about not liking to target arteries, where I like targeting arteries because I could purposely avoid it with ultrasound. But what's interesting with your question is that if you could palpate the tibial artery at the medial malleolus, and you could palpate it up a few centimeters, and that along with using your nerve, your empty nerve finder, you can place your blunt probe in that vicinity and find the nerve, right? So you can certainly find that tibial nerve doing it that way. The other way is not very different than, in the popliteal fossa, if someone's putting a line in someplace else, if you palpate your vessels there, you can always go adjacent and try and catch the tibial nerve there. Obviously, bigger vessel, more risk. But if you come a few centimeters above the medial malleolus, I think you could do it without ultrasound guidance even.
What do you think about the tibial nerve as a non-ultrasound strategy?
Sorry, I just muted myself. No, I think we can go back to the initial 2014 study by Tim Gear, where they with multiple tibial nerves, but nobody was using ultrasound, so it's certainly possible. I think as long as you can feel a little divot in the muscles. I think if you can palpate a pulse, that's but it becomes a little bit of a blind procedure to my taste. But it's certainly doable as long as you have a good sense of your overall anatomy.
So just to be clear, also for those of you that are new to StimRouter, the device is approved for peripheral nerve applications, not including craniofacial applications. So we have one of the broadest FDA clearances of any device ever, which is why you see so many applications of it from these guys. But can you guys comment, David and Einar, on the trialing process? In other words, we don't use a trial electrode or a trial strategy with the StimRouter as we do for more traditional spinal cord stimulation and or DRG stim, for example. Why not, and how do we get such good results without having to do that trial project?
The interesting thing about StimRouter is, of course, your lead is essentially not that kind of expensive. With neuraxial spinal cord stim, you're kind of trying to think about, is this procedure worth a $30,000-$40,000 battery? So it kind of makes sense to sacrifice a lead that some people may get for $100 or $1,000 to see if that $30,000 battery is worthwhile. In our case, if we put in one StimRouter as a test and pulled it back out, then we just have to put in the exact same device. The only step you're really missing is that tunnel. Otherwise, it looks like a percutaneous spinal cord stim trial. So it just makes much more sense to spend 2 more minutes in that original procedure and just go ahead and put it in, because the explant ultimately is very easy too. You just open up that initial incision and grab some forceps and find the lead and just pull it right back out. In my mind, I consider that first paresthesia test when you're already intra-op in some ways to be the trial. And that's why I mentioned, if I don't get good paresthesia when I'm actually doing the operation, I wouldn't complete the procedure. But if I'm in there, I find the nerve, I get good stimulation on the nerve, the patient can tolerate that sense of paresthesia, then I think that's sufficient. In the future, there may be some way to do a little bit of a percutaneous trial, maybe even using some other sort of hardware. But really all you're looking for is, can the patient tolerate that electrical sensation? And it's only been one patient for me where they had fantastic saphenous nerve stim, but just a week or 2 after implant, she wanted it back out. This was a younger female, so I think there was just kind of a concern about having anything implanted in her body. But thank goodness this wasn't a $100,000 full spinal cord stim system that came right out. But in someone like that, it could have maybe been useful to have some sort of temporary lead that isn't the full StimRouter that hangs out of the skin, and you would just pull in clinic if they didn't tolerate the sensation.
Dr.
another
Grigsby,
sort
I
of
don't know if
technical question. If you have a situation where you want to use, sorry, go ahead.
Well, I was going to say, Dr. Grigsby, I don't know if one of the attendees had the question about, it says, do you get complete coverage of the knee post total knee arthroplasty with saphenous stim? And have you tried the genicular nerves?
So I think if you get high enough on the saphenous nerve, like I mentioned, above the infrapatellar branch, you could just go for that main nerve and have pretty good stimulation. So far, I've been kind of trying to pick off that single peripheral branch if I could. In terms of separating from geniculars, I really think of what I'm treating with this post-TKA pain is more the superficial cutaneous nerves that have been damaged. If that step doesn't work, that infrapatellar branch or saphenous block doesn't work, then the geniculars are my next step. Finish those with the RFA.
I would only add, I've done well with mostly single saphenous implants for post-knee arthroplasty pain. I've had a few patients who have more of an anterior component versus a medial, and I've placed the lead along where the anterior femoral cutaneous branch could be in that soft tissue, in that fascial plane. So I have been able to cover the anterior part of the knee by placing a second lead as well. And I have very few patients with lateral sided knee pain. It's typically been medial and a few anterior, and I was able to pick up the rest of it with that second lead.
So thanks, guys. Can you talk a little bit about, in the last couple of minutes we have, a little bit about the external pulse transmitter, and if you have two electrodes in, for example, some of our guys have done axillary and suprascapular and ilioinguinal and genitofemoral. So how do you do technically? Can you drive both of those with one external pulse?
Right, so for the patients where I've placed double, we have been able to drive them together. That being said, there is an advantage to placing the receivers enough distance apart as well, so you could steer them separately and have individual control over them. I think the jury's still out a little bit on which approach is ideal.
Yeah, I think the main issue with two stimulators and one battery is simply you can't kind of program more juice to one or the other. So if the depth under the skin is a little bit different, maybe when you turn up the voltage to 1 or 2, you have great stim on one, but it's not enough or way too much stim on the other. The dual stim routers I've done have typically been, as David mentioned, kind of a bit apart. The one thing I would say is it is possible to stimulate two nerves with one electrode. For example, one patient had ilioinguinal groin pain as well as lateral femoral groin pain after about 13, 14 groin surgeries due to complications after vascular access and angioplasty. And I was able to place the lead over the iliacus close to the transversus, where she actually had really good stim in both of them. But overall, I typically think of StimRouter as being my first choice for mononeuropathies. In a few cases, a couple of nerves if the patient's okay with having two batteries. But once it gets anything more than that, then typically the patients will pick something that can all be powered by one power source.
All right, guys, thanks. It's Eric Grigsby again. I just want to say thanks to all the participants and say that you can reach out to me or to anybody at the company anytime if you have technical questions. And at this stage, I'm going to turn it over to Mark Geiger, who's our Global Director of Marketing, and say a last thing or two.
Yeah, this is Mark. Thank you, Dr. Grigsby. And I'd like to, on behalf of all of us here at Bioness, thank you very much to Drs. Ottestad and Spinner for sharing their expertise. I think between them, they've got close to 80 implants now of a StimRouter peripheral nerve stimulator, and we're very excited about the future and whether it is where do I get training, or what are the reimbursement codes, or how can I get the product into my institution. You can contact me directly at mark.geiger@bioness.com, and I can funnel you to the correct person that we have in the field to assist you. Or you can reach us through our website, stimrouter.com. Again, thank you so much to all the attendees. Thank you, Dr. Grigsby, and thank you very much to Drs. Ottestad and Spinner for all of your thoughtful teaching. And have a great week. Thank you very much.
Thank you.